Welcome everybody, welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual. And today, first I want to start off by apologizing for my nasally congested voice. My voice is never that great, but today it's exceptionally horrible due to probably some virus I have, hopefully not COVID. I'm vaccinated. But anyhow, let's get started. Today I'd like to talk about some rules that have to do with more clinical care tips. Rule number 70. Every child with abdominal pain must jump. So this goes back to rule number 1. Remember, rule number 1, it's not the patient's job to prove that they're sick. It's your job to prove that they're not. So when I see a child with abdominal pain, it is my job to prove that the patient is not sick, meaning he doesn't have a surgical abdomen, he doesn't have anything serious, and if he goes home today, he or she will be fine. So that is rule number 1, and that is my primary role with every patient. Now, with regards to abdominal pain, there are many ways to do that. You start by history and physical exam, and one of my tools for physical exam is making the child jump. I consider appendicitis to be a fairly easy diagnosis to make in older adolescents and adults. I don't see adults, but whatever. In children, however, especially toddlers, it's very, very difficult. They often come in with very nonspecific symptoms, abdominal pain, which we see a lot, vomiting, which we see a lot of, and oftentimes the diagnosis is missed. The child goes home and comes back a day or 2 or 3 later with a perforated epi, and it's very unfortunate. So in order to avoid that, I try to get a very good abdominal exam. And one of the ways I try to rule out appendicitis or peritoneal signs in a child is I make them jump. And I make it more like a game, not exactly part of my physical exam. So when I palpate the abdomen and the child seems to be uncomfortable, maybe even crying, I say something like, "Hey buddy, can you do me a favor? I think you can jump really high. Can you get out of bed and show me how you jump really high?" Oftentimes when I say that, the child thinks we're about to start a game or some sorts, and they get out of bed and give me a nice big jump. I think it's very hard for a toddler to have peritoneal signs or peritonitis and be able to jump. An adolescent, maybe. I've actually diagnosed a few adolescents with appendicitis that did actually jump for me. But I think it's going to be very hard for a toddler to give you a good jump if he truly has appendicitis/surgical abdomen/peritonitis. So every child with abdominal pain must jump. Jumping is my test for peritoneal signs, and I actually document that. Child is able to jump, no peritoneal signs on my chart. Again, going back to rule number 1, it's not the patient's job to prove that they're sick. It's your job to prove that they're not. I think in a toddler who's complaining of abdominal pain but is able to give you a nice big jump, it's very hard to argue that he or she has appendicitis. So rule number 70, every kid with abdominal pain must jump. Rule number 71, remember the 3 to 5 days rule for bronchiolitis. So bronchiolitis is a very, very common condition/disease we see in the winter. Some of us refer to it as the disease that only time will cure. It's probably true. Nothing seems to really help those kids, unfortunately. And it's sometimes very challenging to decide what should be the appropriate disposition for certain patients. So the clinical picture of bronchiolitis varies a lot. Many times just the kid comes in with some mild wheezing. Some kids get into severe respiratory distress, rarely needs to be intubated. Since the incorporation of high-flow nasal cannula, I think the need for intubation is decreased significantly. However, many kids end up in the PICU, kids end up in the PICU for a fairly long time, and it's sometimes very challenging to decide what is the appropriate disposition for this patient. It's essentially impossible to predict how the child will do if you send them home. That is why I use what I learned as the 3 to 5 day rule. This is something I learned in residency. So from what I learned, bronchiolitis usually peaks around day 3 to 5. That's important for me to know in order to decide for the appropriate disposition for the patient. So let's say I see a 8-month-old with no significant past medical history. He's wheezing, it's winter, by definition that's a diagnosis of bronchiolitis, and he's wheezing to a decent degree. Suction did not really help. He has some abdominal bleeding, some mild subcostal retractions. His PO intake and urinary output are very borderline, and I need to decide if this child is safe to go home. Knowing if this is his first day of illness or day number 5 is very important because, again, the 3 to 5 day rule says that usually bronchiolitis peaks around day 3 to 5. So if this child is day 1 of illness, I think it's very, very likely it's going to get worse, and being so borderline already probably means they should stay in the hospital. However, if the same child is on day 5 of illness, I think most likely will get better tomorrow. With some good education and some good follow-up, I think probably it's safe to go home. I explain to the parents what to watch for, what to do. I usually tell the parents that suction is the only thing that seems to relieve those patients a little bit, so you can feel free to spray some saline in the nose and suction. Remember, one of my rules is to set up the expectations. So I always mention to the parents that if you suction many times, you may get some bleeding. That's okay, because the breathing is a lot more important. I usually discourage them from using albuterol. As you guys know, it's not in the guidelines. However, there's nothing to lose. If they think albuterol helps their child, so be it. But essentially, I provide very good anticipatory guidance if I send the child home. But again, when I think of my disposition, I think of the current clinical scenario and the 3 to 5 day rule, knowing that bronchiolitis usually peaks or gets worse around day 3 to 5. If the child is borderline, day 1 or 2 of illness, I'm probably going to keep them in. However, if the child is borderline and this is day 5 or 6, I feel more comfortable that they can go home and be safe. So remember, rule number 71 is the 3 to 5 days rule for bronchiolitis. Rule number 72. Listen to this, try to remember it, and then I'll explain. 4 if you're 1, 5 if you're 4, 6 if you're 8. Again, 4 if you're 1, 5 if you're 4, 6 if you're 8. So first I want to give a shout out to Julian, my friend from residency, who was a PEM fellow when I was a resident, great guy, who taught me this rule. So this is how Julian and how I figure out the endotracheal tube size that we need for a patient. So one of the things us PEM physicians have to be very, very familiar with is rapid sequence intubation, an intubation of a child that needs it. And one of the skills and one of the important points is to choose the right size tube. And there's a formula out there to choose the right size. I think it says something about age divided by 4 plus 4 or something like that. I honestly don't know because I don't really use it. But my personal experience that before you're about to intubate a child, math is the last thing you can do successfully in your head. I majored in math in high school, guys, and I got to tell you, when I'm about to intubate a child, no mathematical formula is going to work very well for me. So I memorized rule number 72, which basically says 4 if you're 1, 5 if you're 4, 6 if you're 8. So if the patient is 1 year old, I need a 4-0 endotracheal tube. If the patient is 4 years old, I need a 5-0 endotracheal tube. And if the patient is 8 years old, I need a 6-0 endotracheal tube. And trust me, if you plug it in that formula, you'll get the same results. But doing math under pressure when you're about to intubate a child is unlikely to work, in my opinion. I don't try it. 4 if you're 1, 5 if you're 4, 6 if you're 8, and that is the size for an uncuffed tube that you'll need. If you go down by 0.5, you'll get the cuffed tube that you need, and we always try to use cuffed endotracheal tubes in pediatrics. So this is how I figure out the size of endotracheal tube I need in order to intubate this patient. 4 if you're 1, 5 if you're 4, and 6 if you're 8. So you need a 4-0 on a child that is about 1 year of age, 5-0 for a child that is 4 years of age, and 6-0 if the child is about 8 years old. 4 if you're 1, 5 if you're 4, 6 if you're 8. Say it 17 times, you'll remember it forever, and no more math under pressure. And that is it for today, guys. Thank you very much for listening. Again, apologies for my nasal voice. Let's review what we learned. Rule number 70. Every child with abdominal pain must jump. Make them jump and document patient is able to jump, no peritoneal signs. Rule number 71. Remember the 3 to 5 day rule of bronchiolitis. Bronchiolitis usually peaks and gets worse around day 3 to 5. So if you see a child that is somewhat borderline with regards to disposition and is day 1 or 2 of illness, probably a good idea to keep them for observation. The same child, day 5 or 6 of illness, hopefully will do well at home with good anticipatory guidance. Rule number 72, 4 if you're 1, 5 if you're 4, 6 if you're 8. This is how I recommend you choose the appropriate ET tube and avoid doing math under pressure. And thanks again for listening, guys. I appreciate it. Please remember to check out pemrules.com, submit any feedback, any questions you have. I love hearing from you guys. Have a good day. I hope you like the outro. Bye bye.